Good morning. Okay.
Oh, sure. What's your take on the CDC, Johnson temporarily not valid concern?
Similar events were seen with the AstraZeneca vaccine, which is a similar platform. And they were the same types of very rare clots, cerebral, venous, sinus clots, which are very rare. When you see them, you tend to see them in patients on birth control. So with Johnson & Johnson, it's 1 in a million. Very rare. I think it's worth asking if there's a causal link. I don't think it's worth holding the vaccine for longer than that. The risk is very low. What I think you should do is, once a risk is identified, give people information and let them make their own choices. Today, we seem to have this situation where we want politicians and everyone else to make our decisions for us. No, give people accurate information, let them make their own decisions. I feel the same way about supplements. Just give people information about them, let people make their own decisions. Make sure it's accurate information, but then let people make their own decisions. Don't sit there and overregulate the whole bloody thing. If a supplement's good, people buy it. If it's not, they won't, because of information. People need information. If you restrict the flow of information, then you don't have informed consumers. This bit where YouTube is taking down videos of people, experts, who disagree with the party line, no way that should be happening in this society. No way. No frickin' way. Give people information and let them make their own decisions. That's my take. Maybe that's too libertarian for some people, but I think science can only flourish if there's a free exchange of information. If the public sees the process, for people to sit there on high, Fauci was so good during the AIDS epidemic. Fauci has changed his mind more times than my wife changes shoes. It's ridiculous now. Now he's telling you after the vaccine, you still have to wear a mask. They want kids 5 years old wearing masks when there's no good evidence wearing a mask at that age actually helps. No, Fauci has worn out his welcome, it seems to me. So, okay, folks, let's go ahead and get started. Good morning, everyone. We have some rather cold weather coming our way. We thought this was all behind us. I guess it wasn't. So today we're going to talk about coagulation. Coagulation pathway is very complicated. So kind of batten down the hatches and get ready for something that is pretty tough to learn. Yeah, Lydia, if you want to put those down, the sun's coming in, it gets pretty hard to deal with. At least they go down in this building. Whiteman Gibbs, they don't even go down. All right. Oh dear, that's glary. You guys see that back there all right? You can? Oh, okay. That's better? Okay. Then that's what we'll do. Let's go ahead and start with a word of prayer. Father, thank you for this day, for sunshine, even though there's cold temperatures. Now, please, Lord, put us in the right frame of mind and mood to learn about this very tough topic, but very important topic medically speaking. Thank you for every student here. Please keep us on the straight and narrow. Keep us healthy. Thank you. Vaccines have come to this campus. May many people take them. In Jesus' name, amen. Okay. So platelets, as we said, they're born from bone marrow. They're born from bigger cells called megakaryocytes. They don't have nuclei, so they don't live long. If you inhibit an enzyme in a platelet has to remake it, but the platelet can't remake it. So the platelet gets inhibited for the duration of its life. That's going to be important when we talk about aspirin, because aspirin permanently inhibits an enzyme found in platelets. Therefore, the next platelets that will be made will have a functional enzyme. The platelets that are alive when you take the aspirin don't have that enzyme being functional. That is an important point to keep in mind. These things are going to be promoters of the clotting pathway, So the process by which the bone marrow makes new cells is called hematopoiesis. This is a very heavily studied field. It's been inhibited by the fact that the stem cell, the hematopoietic stem cell, cannot really be cultured very effectively in tissue culture. There have been some breakthroughs in the past 5 years, but to get long-term cultures of hematopoietic stem cells has proven remarkably difficult. So you have a cell in the bone marrow that's a hematopoietic stem cell, HSC. Hematopoietic. Boy, it's a good thing this is not a spelling class. You can see why we call it HSC. That doesn't quite roll off the tongue. This cell in the bone marrow, so this is found in the bone marrow. The cell divides throughout your lifetime. When this cell divides, the daughter cell now is going to contribute to the blood cells in your body. The other cell is going to renew the hematopoietic stem cell. So this population shows self-renewal. That's one of the things you need to be a stem cell, to show self-renewal. This cell can then become either a member of the myeloid lineage or it can become a member of the lymphoid lineage. What determines what type of cell it becomes? The answer is the microenvironment in which the cell finds itself, because the microenvironment will contain growth factors, it'll also contain cytokines. And depending upon the various combinations of growth factors or cytokines, will push this cell to either become a member of the myeloid lineage or the lymphoid lineage. So the lymphoid lineage will make things like B lymphocytes, T lymphocytes, and also natural killer cells. Members of the myeloid lineage make everything else. So they make red blood cells. They make most of your other white blood cells, so they'll make neutrophils, they'll make macrophages, they'll make eosinophils, they'll make thrombocytes, megakaryocytes, and the megakaryocytes will give rise to platelets. So myeloid is everybody else. All right, so the formation of red blood cells is stimulated by erythropoietin, which is made by the kidney. That should tell you why chronic kidney problems can tend to lead to anemia. And then the formation of white blood cells is collectively known as leukopoiesis. And these two processes are stimulated by various types of cytokines that are present in the bone marrow, secreted by stromal cells and other types of cells in the bone marrow. And as certain cell populations are needed, certain concentrations of certain cytokines go up or down, and that will influence the cell types that are made by the bone marrow. If you need more red blood cells, the kidneys make more erythropoietin. You make more red blood cells. If you need more platelets, then the spleen and the liver will tend to make thrombopoietin. That will tend to cause the bone marrow to make more megakaryocytes, which will make more platelets. If you need more neutrophils, then various cell populations throughout the body will make colony stimulating factor, which will cause you to make more neutrophils. If you need more macrophages, certain populations will make GM, CSF, granulocyte monocyte, colony stimulating factor, you'll make more macrophages, and so on and so forth, blah, blah, blah. And the punchline is your bone marrow responds to needs. And those needs are detected by the proportions, combinations, and quantities of these particular growth factors and cytokines. So 2.5 red blood cells are made per second. So if you take a look at your phone, count off 10. You can just kind of look up and say, gee, I just made 25 million RBCs. And mom said I didn't accomplish anything today. Pretty impressive, isn't it? So the lifespan of your average garden variety, run-of-the-mill red blood cell is in the vicinity of 120 days. It gets removed by stationary phagocytic cells, mainly in the spleen, but also in the liver, and to some extent too in the bone marrow. Iron gets recycled. The heme group is converted to bilirubin, and then bilirubin is secreted by the liver into bile and so on and so forth. So how do you prevent the loss of red blood cells by bleeding? The cessation of bleeding is called hemostasis, and it begins when you have damage to a blood vessel. You get a platelet plug, then that platelet plug is reinforced by fibrin. That forms a clot. Let's look at how this happens. So platelets, when they're not activated, do not stick to anything. They flow through the blood. They tend to not secrete anything that tends to disrupt anything. Your endothelial cells, as you can see, make two factors that promote the health and well-being of the blood vessel. They make this prostaglandin called prostacyclin, and they make nitric oxide. Both of these promote platelets that are not activated. They promote the inactivated states of the platelets, and they tend to be signaling to everybody else, okay, gang, we're fine. We're fine. So if you go home, what your parents always ask you when you go home, how are you doing? You could very easily give them a 3x5 card that has nitric oxide and prostacyclin on it and hand that to them and not say a word. And you'd be saying, I'm fine. Now, they might not get it, but if you explain it to them, then they'd say, you're so smart. Oh, my smart little Jessie. Oh, look how smart you are. Because that's essentially, we've learned how to talk endothelium. So I challenge some of you to try that next time you go home. You might get a laugh out of it. Maybe you'll have people roll their eyes, but everyone will be impressed with how smart you are. One other thing. Intact endothelial cells have on their surfaces this protein called CD39. What does the CD39 do? CD39 takes ADP and degrades it to AMP and inorganic phosphate. Why is that important? Because ADP is a platelet activator. In fact, it's a very potent platelet activator, as we will see in just a bit. One other thing. Underneath the endothelial cells, there's a carpet of extracellular matrix. That carpet consists of collagen, but sticking to the collagen is a protein called von Willebrand factor. Von Willebrand factor, and the way my nursing students remember this is as VW, so they remember the VW Bug, the car, that's been remade now. Looks pretty cool, actually. They just assume that there's a bunch of VW Bugs. This is a parking lot for VW Bugs. And it's away from the people who want to steal the cars So here are the carjackers, and here are the VW bugs, and they don't see the VW bugs, so they're fine. But when this gets damaged, now they see the VW bugs. VW actually means von Willebrand factor. But by saying VW, that helps them remember VW von Willebrand factor. Okay. You damage the endothelium. Now the blood sees collagen, and it sees the VW bugs, the von Willebrand factor. Now another thing happens too. Damaged endothelial cells start to secrete von Willebrand soluble von Willebrand factor. That's going to stick to the collagen, and now you don't have prostacyclin, you don't have nitric oxide, you don't have CD39. Platelets now start to stick to collagen and to von Willebrand factor. That activates them. When you activate a platelet, you can see it changes shape. The other thing the activated platelets do is they dump their granules. Platelets are full of granules. They get activated, they change shape, they dump their granules. The granules are full of ADP. ADP is now going to activate any other platelets flowing by in the bloodstream. So this is a positive feedback sort of loop. The granules also contain serotonin. Serotonin. Now you might say, oh, serotonin, that's a neurotransmitter. Yes, but serotonin will also cause blood vessels to constrict. They also cause blood vessels to constrict. By causing blood vessels to constrict, they're going to decrease blood loss from that damaged vessel. Then platelets start to make thromboxane A2. And that's abbreviated here, TXA2. That's thromboxane A2. That's a lipid. Thromboxane A2 acts with ADP to help activate platelets. So let's say Elena over here, let's say she gets home, and let's say her roommate, for the 35th time, left her dishes and dirty dishes in the sink. Okay, I'm just guessing, Elena, that's going to tick you off just a little bit. Is that fair? Now, you go to her and you say, please wash your dishes. And instead of saying, I'm sorry, or going over and washing your dishes, she says, oh, you're so bossy. Oh, you do the same thing. Or you're not my mother, or something, some stock phrase like that. Now, Elena, that's going to tick you off just a little bit more. So the not washing the dishes, that's the ADP. That goes from calm to I'm ticked off. Now you add insult to injury. That's the thromboxane A2. Now you go from ticked off to pissed off. Okay? You see how they layer on each other? You get a platelet that's very, very activated. Now, can ADP do it all the same? Yes, but thromboxane A2 ratchets platelet activation up. Okay, Elena, I'm not bagging on your roommates, not saying your roommates would do that, but I'm just saying if they did that, you'd probably get ticked off. That's fair. That's fair. Good. Okay. Now, when those platelets get activated, they dump their granules. They're now going to express new receptors on their surfaces. And those new receptors on their surfaces are going to cause the platelets to stick together. And they'll also stick to von Willebrand factor and to collagen and what have you. And they're going to form a platelet plug, a platelet plug. Now, if you're an animal with low pressure systems, this is fine. This is how, for example, sea cucumbers clot their blood. They have hemocyte, binds to the site of damage, expands, clots it, clumps together with others, blocks it. Bob's your uncle, there you are. We don't have a low pressure system. We have a high pressure system when it comes to our circulatory system. So that has to be reinforced with fibrin. So now you have a different system that converts a blood-based protein called fibrinogen into fibrin. Fibrin self-assembles into these long cables. Those long cables reinforce the platelet plug. That is what we call a clot. A clot. And here is a picture of a clot. Here are your trapped RBCs, and here's your platelet that has undergone clumping. See how those platelets clump together? And see how they're all ensconced in this meshwork, this filigree of fibrin? That, ladies and gentlemen, is a clot. The platelet plug is then going to undergo contraction, so it's going to fit even more tightly into that piece, that lesion. And now the pressure is going to take it, and it's going to take the plug and push it even more firmly into that damaged area, and it's going to seal it off so you don't lose any more fluid or electrolytes or red blood cells. Okay. Because some people, first of all, platelet reactivity varies from person to person, and then clotting times vary from person to person based on how vigorously you make clotting factors. Some people make a lot of clotting factors, others don't make as many clotting factors, and then those clotting factors are subject to some degree of variation, and then your liver function determines how active your clotting factors are too. So that will also influence clotting factors. That's why there's a variation of clotting activity, and then your diet can affect that too, because certain foods, certain additives, certain supplements you might take, those can affect clotting as well. So me, for example, I'm a bleeder. When I get any sort of procedure done with a needle, I ooze, I bleed. Do I ooze for long? No, but I always get asked, are you on a blood thinner? No, I'm not, I'm just a bleeder. And it happens with some people. Every time I get a shot, I'm gonna ooze a little. Do I ooze a lot? No, but I ooze a little. Most people don't, but I do. That's just the way I am. Okay, so the platelet reaction is going to be broken into 5 steps. There's first damage. Damage to the endothelium. That leads to the second step, that's exposure. So when we say damage, we mean damage to the endothelium. When we say exposure, we mean exposure to collagen and von Willebrand factor, the VW bugs. So the third step involves the adhesion. When we say adhesion, we should always ask adhesion to what? That would be the adhesion of the circulating platelets to collagen and the von Willebrand factor. Remember, the damage in nearby endothelial cells also start to secrete von Willebrand factor as well. And then the fourth step is going to be activation. So activation involves the platelet release reaction. And what are the platelets releasing? They're dumping their granules. And let's play a little game here. We had it on the slide before. When I point to you, just tell me something that's in the platelet granules, Josh. Thromboxane A2. Ben? ADP, Jesse? Serotonin. So there's other things, but those are three big things that you should definitely know. Thromboxane A2, ADP, and serotonin. Okay, step 5 is aggregation. Aggregation involves the exposure of a new cell surface protein. And this is your glycoprotein 2B3A. Glycoprotein 2B3A binds to fibrinogen. Fibrinogen that's circulating in the blood. They bind to fibrinogen and they all stick together. It's kind of like if you're in a boat and the boat overturns, and then while if you're in the water, you're separate. Here comes this big log floating down. You all grab onto the log, and now you're all floating down the river together. You're all aggregated together because you all used your receptors, your 2B3A, to grab onto the log, and now you're all aggregated. So those are the 5 steps of forming the platelet plug. 5 steps of forming the platelet plug. So the formation of fibrin can occur through one of 2 pathways. There is an intrinsic pathway. The intrinsic pathway is called intrinsic because it occurs inside blood vessels. So this is for blood vessels that are damaged. Intrinsic pathway. Then there is an extrinsic pathway that will activate clotting if you have damage outside blood vessels, in a organ or tissue or something like that. And the capillary beds will detect that, and that will then provide signals that will cause clotting in vessels upstream, essentially. So the damage occurs outside the vessel, and you get clotting activated that way. Intrinsic pathway, extrinsic pathway. Page 78 has the pathways on this handout here. Page 78, if you have your notes, please get that out. Let's go ahead and go through it. If this looks complicated, that's because it is. This is not simple. This and this are the same thing. Now, I want you to notice both the intrinsic and the extrinsic pathway feed into a common pathway. A common pathway. And on your handout, this 10, factor 10, that is the start of the common pathway. So let's do the intrinsic first. That's easier. So the intrinsic pathway usually involves the exposure of the blood to collagen. Now, if you take blood and put it in a glass tube, it's going to clot. The reason for that is that the intrinsic pathway is also activated by glass. That's why you never put blood into glass unless you want it to clot. Now, if you don't want blood to clot, here's what you do. You take away the calcium because this pathway must have calcium. It must have calcium. So to get blood not to clot, you can use citrate, sodium citrate. That'll grab all the calcium. Or you can use ethylene diamine tetraacetate, which is mercifully abbreviated EDTA. Either one of those will take away the calcium and the blood won't clot. And when you use tubes to draw blood, very often many of those are coated with sodium citrate or have a citrate gel or something like that to keep the blood from clotting. Now, the factor that kicks off the intrinsic pathway is called factor 12. Clotting factors are made by the liver. They're made by the liver. These proteins are expressed as inactive precursors called zymogens. That was one of the words on your vocabulary, zymogens. Zymogens are enzymes that are made as inactive precursors, but they become activated when you clip them into shorter versions. The shorter version is active. Longer version is inactive, but you clip them to the active version, but they're made as the zymogen, the inactive precursor. So factor 12 binds to collagen, binds to glass, binds to stuff like that, changes conformation. When it changes conformation, it becomes active. It now clips factor 11. Factor 11 now is a shorter active version of itself. Factor 11 will now clip factor 9. 9 now goes from this big to this big. It's now a more active version of itself. So 9 together with calcium, phospholipids, and factor 5 will clip factor 10 to a shorter version of itself. Factor 10 is now active. 10 will clip thrombin, prothrombin into thrombin. Thrombin is a powerful protease. It will clip the blood-based protein fibrinogen into fibrin. Fibrin will self-assemble into cables. You can generate fibrin in a test tube. It'll generate these cables all by its lonesome. And that forms a fibrin polymer. Now, once you form fibrin polymers, there's another factor called factor 13. Factor 13 goes in, takes those fibrin polymers and cross-links them. That takes hours to happen. This is a maturation process of the clot. This stabilizes the clot. This is sometimes called the curing, C-U-R-I-N-G, of the clot. That's going to be important when we talk about thrombolytics. That's the intrinsic pathway. The intrinsic pathway. On your handout, you see this thing that says HMWK. That stands for high molecular weight kallikrein. High molecular weight kallikrein. Kallikrein is a protease released from damaged endothelial cells. Kallikrein is a protease. Kallikrein can actually activate factor 12 as well. So factor 12 has more than one way to be activated. Now, let's say Sarah over here is playing intramural soccer. And let's say she gets on the soccer field, she all of a sudden becomes really competitive. And so she really goes to the ball hard and she runs into somebody. Let's say she runs into Mr. Lamphere back there fairly hard. And Zach, number one, being a gentleman, number two, being one tough mother, essentially goes, oh, sorry. And Sarah, then the next day, discovers she's got this discoloration of her skin. What happened? Well, she ran into Zach, of course. But Sarah broke blood vessels. She had clotting occur in those blood vessels, and she released lots of hemoglobin. Then that hemoglobin gets broken down into hemocyanin. And that essentially is the bluish, blackish color that you see in the bruise. And that's how the bruise gets cleared. Eventually, as cells come in, eat up the iron, recycle it, but that's essentially what caused the bruise, is the blood that comes from the broken blood vessels. What about the extrinsic pathway? The extrinsic pathway is much easier. So cells have on their surfaces this protein called tissue factor. Tissue factor. This is particularly found in the endothelial cells of capillaries. It's found in lots of other cells too. When those cells are damaged by trauma or something like that, they release their tissue factor. Tissue factor released into the blood. Tissue factor is also called tissue thromboplastin, binds to factor 7. Factor 7 plus tissue factor, or tissue thromboplastin, now becomes an active protease. And in combination with calcium and phospholipids, it will clip factor 10 into its active form. That's the extrinsic pathway. Okay, gang. This pathway is very heavily regulated. There are some proteins I want to tell you about that help regulate this, because when this gets activated, it is a positive feedback sort of situation. So there are some proteins that essentially say, whoa, stop, don't go so fast, slow down. Those are going to be important here in just a bit. So let's tell you about them. First of all, thrombin is regulated by a protein called antithrombin 3. This binds to thrombin and inhibits it. So thrombin gets activated, but it keeps thrombin activation within a particular window. Then there are proteins. There's a protein C and a protein S. Protein C and protein S regulate not just thrombin, but several other clotting factors as well, in particular factor 10. So these also negatively regulate the clotting pathway. There are others, but these are the ones I want you to be aware of. Antithrombin 3, which gets abbreviated usually AT3. And then protein C, protein S. C and S work together as a complex. And if you, so CS is the initials of my favorite cartoonist, Charles Schulz, who wrote the Peanuts comic strip. So if you need to be reminded of this, just remember Charlie Brown, the star of the Peanuts comic strip, whose author, the cartoonist was Charles Schulz, CS. Nelson? These, if you're deficient in these, you'll clot too often. And there are people with deficiency in factor S. Factor S is more common. Deficiency is more common in factor C deficiency. There's antithrombin 3 deficiencies. They're more prone to clots and what have you. So yes, but they'll cause you to clot more vigorously, more often. Didn't want to do that. All right, this pathway, how do you remember this pathway? How did I learn it? I learned it by drawing it and redrawing it and redrawing it. And then explaining it to people helped me learn it too. So we'd explain it to each other, and that kind of helped us learn it correctly. When you make a clot, when endothelial cells have a clot nestled against them, they start to secrete a protein called tissue plasminogen activator, or TPA, tissue plasminogen activator. Tissue plasminogen activator will take a plasma protein called plasmin and it'll activate it. Plasmin is a vigorous degrader of clots. So that's how clots get removed once healing has taken place. They get degraded by this enzyme plasmin. Plasmin comes from a zymogen, plasminogen, also made by the liver, and it activates plasmin, TPA does, and the plasmin degrades the clots. Now, there is another protein that will activate plasmin called urokinase. Urokinase is found outside blood vessels. Outside blood vessels. TPA is found inside blood vessels. Inside blood vessels. And then there are a variety of anticoagulants that we can talk about. The big ones I'm going to highlight here are just the ones you use in the laboratory, sodium citrate or ethylene diamine tetraacetate. These others we will talk about. All right, clinical thrombosis. So I keep trying to update this data every year, but it really doesn't change that much. So there's about 3 million cases or so of deep vein thrombosis in the US. There's 10 million cases of venous thromboembolism worldwide. So in the US, you have about a little over 600,000 cases of pulmonary embolism per year. You have about 50 to 60,000 deaths per year from pulmonary embolism. And then the pulmonary embolism will contribute to death by other causes, about 150 to 200,000 those deaths per year. And then post-surgically, there's about 11,000 deaths due to pulmonary embolism every year. Just to clarify, a clot that forms in place is called a thrombus. A thrombus. If that clot dislodges and floats around the blood, it's now called an embolus. An embolus. So clot in place is a thrombus, a clot that's detached and sojourning through the bloodstream is a embolus. And if that embolus clogs a vessel, that's called an infarction. So when do you use antithrombic therapy? You use antithrombic therapy whenever someone gets a clot or whenever they undergo a procedure that will put them at high risk for a clot. So for example, hip replacement, knee replacement, shoulder replacement, any of those procedures greatly increase your risk for clots. So if a patient has either a deep vein thrombosis, usually in the legs, or a pulmonary embolism, you have a clot that's dislodged and has lodged in the pulmonary circulatory tree, or primary prophylaxis or prevention of deep vein thrombosis or a pulmonary embolism. So who's at risk? People with prosthetic heart valves are at increased risk. Why? Because you have a synthetic valve, you have a synthetic surface. That synthetic surface puts you at increased risk for throwing clots. People with mitral valve disease. And then especially if you throw in atrial fibrillation. With atrial fibrillation, blood is pooling in the atria. If it pools in the atria, it's going to clot. Congestive cardiomyopathies, again, bigger heart, more chances for blood to pool, greater increased risk for a clot. Atrial fibrillation, blood pooling, you're going to have a clot. Mural cardiac thrombi. If you've had a heart attack, you roughen the side of the heart because that tissue is dead. You roughen it, now you have an area that can cause either the formation of clots or it can cause clots to stick to the wall of the heart. That's a mural cardiac thrombus, potentially very dangerous. Trans-ischemic attacks. Next to this, I want you to write stroke. Stroke. That's what a trans-ischemic attack is. A stroke. Miss Amanda, can you tell me what a stroke is? Very good, exactly right. So that embolus gets stuck in the small vessels leading to the brain, causing brain ischemia and death of brain tissue. That's a stroke or a trans-ischemic attack. And then stroke in evolution. That simply means you have a stroke that has evolved because of a clot forming from damage someplace else. This can be the case, for example, after a car accident. You have a crushing injury to the lower limbs, you're at greater risk for a stroke. If you have a machine accident where the hand is crushed, that could be stroke in evolution. You have blood pooling somewhere in your body because of damage, compartment syndrome, something like that. That could be stroke in evolution. So these are things essentially that merit antithrombic therapy. And then DIC, or disseminated intravascular coagulation. This occurs if you have an infection from usually gram-negative bacteria. The cell wall will cause massive clotting on the inside layer of the blood vessel. And now you use up all your clotting factors. And then maintenance of patency in vascular grafts. If the vascular graft fails, you'll get a clot usually where that graft has failed. So this here just shows you essentially the what's what. You have damage to tissue, damage to endothelia, platelet aggregation, clot formation. You get the formation of a thrombus. It can be either in situ, or you can have an embolic obstruction that leads to ischemia or infarction or both. And so you can generate plasmin that will degrade the clot, or you can just prevent the clot from forming in general by giving an anticoagulant or an antiplatelet treatment, as you show here. So first, you reduce risk factors. We'll tell you how to stratify risk factors. Then there are platelet inhibitors that prevent platelet adherence and activation. Then there are anticoagulants that prevent the formation of the fibrin, and then fibrolytics that you can use if a clot has actually formed. Remember, platelet inhibitors are used for clots in arteries. Anticoagulants are used for clots in veins. Please don't forget that distinction. That's a very important distinction. And this is just reminding you of what we've gone over again. You can see protein C and S with this protein thrombomodulin, inhibits factor V, inhibits factor 7. Antithrombin is going to inhibit thrombin and factor 10, blah, 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 and so on and so forth. Tissue factor plasma inhibitor, and then factor 13, blah, 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 and so on and so forth. So that's kind of the whole scheme here. This simply shows you how you make fibrin from fibrinogen. You clip these small polypeptides here. Now this will self-assemble. It self-assembles via non-covalent type of associations, but this will self-assemble. You get the polymer, factor 13 will come in and cross-link these very effectively. Then when you degrade them, you get things like this, but one of these is called a D-dimer. D-dimer. D-dimers are going to be an important test that will tell you if someone's had clots. The D-dimer. Please remember that. Okay, here is how you assess risk for clot. You're going to use the CHAD-VASC scoring system. The CHAD-VASC scoring system. So you're going to ask these questions. If it's yes to any of these questions, you're going to give the patient either 1 or 2 points. Congestive heart failure, yes, that's a point. No, it's a 0. Hypertension. And with this, you could say controlled or uncontrolled, but usually if there's hypertension, even if it's controlled, you give them a point. If it's well controlled, many cardiologists or hematologists look at that and say, yeah. But if there's hypertension, give them a point. Greater than 75 years of age, that's 2 points. Diabetes, that's a point. If they've had some sort of clotting event before, that's 2 points. Vascular disease, peripheral arterial disease, prior myocardial infarction, something like that, that's a point. Age, 65 to 74 years old, that's a point. Sex category, particularly if they're females, particularly if they're females either on birth control or if they're postmenopausal, that's a point. Then, if your score is 0, you don't recommend anything. If their score is 1, then they're on aspirin or some sort of oral anticoagulant. If their score is 2, they need to be on an oral anticoagulant of some sort. And if it's more than 2, definitely oral anticoagulant. And this simply stratifies the risk and shows you how your risk of a clot, how your risk of stroke per year goes up as your CHAD-VASC score goes up. This is from enormous amounts of data. This is very well established. This test is really the best test you can give to someone, essentially. So notice how this climbs. That's why it's important to control this if there is an issue. All right, questions? I think that's a mistake. I think that's a mistake. Let me look that up. I might have typed that in wrong. I thought I cut and pasted it, but I might not have. I think I might have mistyped that. Let me check that. I'll bet you that's a mistake. Katie? Kate? Yeah. So is Thursday gonna work for you guys? So the 1 o'clock works?
Yeah.
No interview?
No,
Okay.
got the job.
Well done, well done.
Yeah.
And one's good for you? Let's do one then. I'll make a Zoom, send it out to you guys. Study tonight, get some questions, and I'll see you guys then at 1.
Sounds good. Thank you.
Great, yeah.
Yeah,
So I watched 2 of the science seminars for credit, but for the third one, can I use that as an extra credit? Do I have to write something for that or just tell you I watched it?
just watch it.
Okay, sounds good. Thank you.
Yeah,
I was wondering if you saw my email for scheduling our meeting to discuss my Bio460
yeah.
project.
Okay, Thursday, today is terrible.
Yep,
Um,
I'm pretty